1991 and 1992, he became a PhD student in the biomechanical department of the Technical University in Hamburg, where he received his doctorate in 1996. In 1997, he became head of the research department at the Center of Musculoskeletal Surgery at the Charité. In 2001, he became professor in the biomechanical and biology of bone healing. Since 2008, he is the director of the Julius Wolff Institute and professor of biomechanics at the musculoskeletal regeneration. Professor Duda is also involved in the research on the regenerative medicine. With his work, he aims to understand the body's own processes and, where necessary, to stimulate them so as to reproduce the natural regeneration of the musculoskeletal system. Since 2018, he is a visiting professor of the regenerative medicine and musculoskeletal sciences, University of Oxford, UK. He is the first German scientist to deliver a prestigious K.T. Dholakia lecture. This is only eponymous lecture in the India which focuses only on the basic sciences and research. I invite Professor Duda to deliver prestige K.T. Dholakia lecture. Please come, sir.
Dear Chairman, dear ladies and gentlemen, it's a great honor and a great pleasure to give that Dholakia lecture. And I'd like to briefly say a couple of words. I haven't had a chance to meet Dr. Dholakia. But if you look into the internet, you find at Wikipedia quite a bit of illustrations that are just rough words and give a little bit of an impression. If you go deeper, you find an article describing his efforts and achievements to initiate, form, and drive forward the orthopedic community in India, and specifically the joint replacement surgery strategies and concepts. But that doesn't really tell anything about his personality. And I found it extremely interesting. If you dig a little bit deeper, you find some other descriptions about him, because that is also if you Google. And then you find a description that is given at the bottom here of a young lady basically experiencing or telling about what she experienced in her interaction with Dr. Dholakia. And in that sense, I'm very thrilled to give that lecture, because I think he laid the foundation for a lot of thoughts and thinking that you have here in the Indian Orthopedic Research and Orthopedic Practical Society. And I'd like to enlighten a couple of thoughts and ideas that we are trying to drive forward in my institute. I have the privilege to lead the Julius Wolff Institute, and Julius Wolff was the first orthopedic surgeon at the Charité, and Charité is the University Hospital in Berlin of the Humboldt University. And I'd like to illustrate a little bit the ideas that we have on bone and muscle regeneration. What are we known for? What do we sort of have printed or left footprints? My partner, Georg Bergman, and me have looked into loading of the human system. And Georg Bergman developed a device that allows to measure the forces in vivo in patients. And that concept has been used to measure the forces in the shoulder joint, the hip joint, the knee joint, and the spine. We have a number of patients that we are at the moment still measuring, in which we can actually measure the forces that the patients actually have. And we just had in the last session the topic of unloading. And can we actually unload the limb, or is that impossible? If you'd like to know more about that, please go to the OrthoLoad homepage, where we are preserving or giving you the chance to look into the forces that are accepted in the human body. Those forces are the basis for any preclinical testing of any joint replacement that you can buy on the global market, and they are the basis for the ASTM, ISO, and the Asian standards. Just to illustrate how much load is in the human body, I'd like to share with you that one video. That's one of our oldest patients who's wearing a hip replacement. So we're measuring the forces in the hip joint. So what you see on the left-hand side is the forces, and the black line is the resultant force component. And it goes up to 2 times body weight in that activity. And if that patient is basically standing on the head, so not loading the feet, he still has 1 time body weight at the hip joint. What I want to show with that video is there is no way that you get away from the loading that are acting in the hip joint, because this is what the muscles actually do. There's another example if we walk. And we have a lady here walking, and we measure at the hip and at the insole, so at the foot and at the hip joint. As expected, you have forces at the foot which are roughly 1 time body weight. But at the hip joint, she has forces of 2.5 times body weight. Why 2.5 times body weight? Because of muscle contraction. Muscle contraction dominates the activity and the loading at the hip joint. Is that how we always walk? There are other people who have different patterns of walking. And that's a lady pretty much the same age, the same speed, the same activity. But if you look carefully, this lady on the right-hand side walks with 3.5 times body weight. So she easily has 1 time body weight more on the hip, just because she has a different way of using her muscles. She uses higher core contraction forces. The lady on the right-hand side is easily somebody who is going to sort of suffer from OA earlier than the one on the left-hand side. So now I illustrated a little bit the forces that are acting in the musculoskeletal system. Now you have to solve a problem because you have a large bone defect. You know it's heavily loaded, and what solutions can you actually come up if you have, after a fracture, or like in this case, after a tumor destruction, or in infection situations, a large bone void, and you need to fill that, and you need to find solutions for those patients. There are a couple of existing strategies, and you may be well aware of using them, or some of you may even use them. But overall, we don't really find that there is one great solution. We still see that this is an unsolved medical need. We tried to overcome that in Berlin with a slightly different strategy. We used 3D printing. Together with a company, we made titanium scaffolds and made a 3D printing of those scaffolds. On the left-hand side, you see an example here. This was treated initially with a fibula grafting, and the fibula grafting was so nice that we wanted to keep it because it was distally integrated. So we actually made a 3D printed scaffold that can basically take that fibula grafting on board. But in the end, the question is there really bone filling happening in that case, or is it just looking nice in the beginning? You see a little bit of bone formation at 1.5 years, but not really massive. That's another case. We did in total 21 cases. After 8 months, complete fracture and failure. We had the chance to get the samples in the histology lab, and if we look into the samples, we see there is anything but titanium, but fibrous tissue, but no bone formation. So it looks nice in the X-ray, but it doesn't work. It seems to give not enough chances to the bone to form. Why? We believe it's stress shielding. We basically have a too stiff structure, and that doesn't allow the bone to actually heal. How could we overcome that? Could we basically make titanium mesh scaffolds such a way that they are mechanobiologically optimized to promote bone healing? And we can do that by really choosing the different structures for such scaffolding. We realized that a honeycomb structure is much more beneficial than any of the other structures. So it's not only about doing 3D printing, but it's about how to do it and how to position it. And what we basically did is we produced 2 scaffolds that we wanted to test in sheep. And one design is basically illustrated here on that side. It's half the stiffness what we had in the patients, and that one here is 1/3 of this one. So we basically have 2 stiffnesses. The only difference between the 2 scaffolds is the beam thickness. So the strut of the titanium is a little bit thinner in the soft scaffold than in the stiff one. We have, as a study design, used sheep. We have the 2 different scaffolds, 1/3 in the one, soft one, and the stiffer one, half of what you had in humans. We put autologous bone grafting in the scaffolds, put them in the defect, and the most important thing here is we used an LCP with dynamic locking screws. and let them walk for 24 weeks and see the healing. In the stiff scaffold, we do see a little bit of bone formation, as you can see here on the right-hand side. But in the soft scaffold, we actually had a massive, more pronounced bone formation. So here it suddenly does work because we have an elastic system. You see always more bone formation on the lateral side than on the medial side. The histology is on the top. The black is the bone. And it matches what we have found in the finite element analysis of the straining. So we really have in the flexible, soft one, more straining than in the stiff one, even after bone formation. We have more bone formation in the soft scaffold with LCP than in the stiff scaffold. And very interestingly, we find cartilage formation, so ongoing endochondral in the soft one, but we hardly see that in the stiff one. If you now replace the LCP and dynamic locking with a very rigid fixation system, like we did here, you can basically block the biological process. So you have the right scaffold, but the wrong fixation, and the fixation basically kills the process if the fixation is too stiff. So never be too stiff. If we look in the bone formation in detail, we see that the patterns of the bone formation and the collagen networks that we can see on the right-hand side are highly aligned and really surround the titanial scaffolds. So it seems to be that the collagen organization is really using the scaffold and really follows the scaffold structure. And if we look into the whole scaffold, here the full length of the scaffold in high resolution, you see that there are really little mineral particles starting to mineralize, and then lamellar bone is forming on top, and a very nice bone formation across the whole defect. Now I showed you one approach. I'd like to share with you a second approach where we use resorbable scaffolds. We have compared, together with Dietmar Hutmacher, autologous bone grafting, just a PCL scaffold and a PCL scaffold loaded with BMP7. And certainly BMP7 does the job. That's why I'd like to concentrate on the scaffolds without BMP and just the pure scaffold. What we could find there, if we looked very carefully, was that stalagmite bone formation in the cavities of the scaffold. So the scaffold seems to really guide the bone formation to form little peaks and actually go forward. And if you do a histological section on one of those peaks, you can easily see that there is such a cone here in dark yellow, surrounded by fibrous tissue that really goes into the scaffold. And it looks like if the cells are actually holding on each other and surrounding that scaffolding and forming the cone. The cone at the top has osteoblasts, the bone-forming cells, and in the middle has osteoclasts and bone marrow and osteoblasts. So it's already completely natural bone that is forming inside. If you do an imaging of that scaffolding, we use second harmonic imaging, you can basically see that the collagen fibers really run from the scaffold into the bone cone and are really transferring the load from the scaffolding into the bone. So it illustrates that there is really a continuum between soft tissue and hard tissues, and that we need to drive that process and keep the process of endogenous bone formation ongoing. What I tried to illustrate to you so far is that there is no chance to get rid of the loading in the human system. And by the way, any tissues are under pretension. None of the tissues, even the soft tissues, is unloaded. The scaffold can be used to induce endogenous bone formation and shift the extracellular matrix structuring organization. And the mineralization, the bone formation, follows the collagen network. And if you put the collagen network in the wrong place, the bone cannot heal. If you basically have a scarring, the mineralization will not run the way you would like to see it. Can the bone actually be pushed in the defect, or is it actually pulled by the soft tissues? We don't know yet. And 3D printing seems to be a technology that allows us to engineer 3D bone formation across large defects. But it requires dynamic fixation, a certain flexion inside and outside, nutrition supply in the defect area. If it's too stiff, all the effect is going away. So far, I basically talked about intramembranous bone formation. You know there are two ways how bone is forming. Bone can position on one of each other, or like in the growth plate, it can basically form in the growth plate process. The intramembranous ossification is what any of the products that you can buy also outside here is trying to induce. So it's always intramembranous ossification that is tried. But actually, in nature, we are growing and we are making bone by ourselves through the growth plate, through an endochondral ossification process. Would it be possible to induce endochondral ossification in a large bone defect? Could you actually make bone growth plate behavior in a large bone defect? What is actually happening in a defect? In a defect, the situation is, at this top you see micro-CT images, 5 days, 3 weeks, and 6 weeks. And you know if the bone is not forming, it comes to a non-union and you have a closure of the bone marrow canal. What is actually happening there? And I'd like to really sensitize you to the fact that in the very early phase, you have already here fibrous tissue organization that tries to cover the bone marrow. So there is an intrinsic interest of the bone marrow to be closed. And that's happening within the first couple of days. It's mature after 3 weeks, and it's even more mature after 6 weeks. If you look into that, you see that there is a collagen fiber, and behind the collagen fiber is the bone mineral matrix happening. So if you basically produce a gap, if you don't reduce your fracture, there is a high chance that fibrous tissue runs in and basically avoids any bone formation. What you see at the bottom, I just go back once, is the bone marrow. The bone marrow is that very light color here. The bone marrow is kept in place after 5 days. It really covers and is covered by fibrous tissue at 3 weeks and is completely secured after 6 weeks. So whatever you would like to do to get bone healing to form, you need to avoid that the bone marrow cavity is closed. You need to get the bone to actually travel forward. How could you do that? You need to keep the pores open. You need to get the process going. How could that be seen? That could be seen like you need to provide the cells that you want to have from the bone marrow, you need to provide them tracks to go from one side of the defect to the other side of the defect. If you have a fracture gap, you try to get through the fracture gap. You need to bridge from one side to the other. How can you do that best? There is an intrinsic capacity of cells to walk and migrate. What you see here are fibroblasts. They walk from one side of the bone to the other side. And you can actually guide that process. If you provide tracks for the cells to migrate, then they actually move very far, A, or if you put the scaffolds in the wrong way in, B, you produce a scarring. So you can basically organize a scarring or avoid a scarring by just providing the right infrastructure and frame. So we're lucky to work together with a small company. They provided us with collagen. It's a highly organized deep freezing process that provides such a highly structured collagen network. It's a very soft material. It's an experimental approach that we choose here, and the most important number is 98.5% nothing. So it's a biomaterial with a lot of nothing and 1.5% something. And that 1.5% something is collagen. So a lot of nothing and only very little collagen. The collagen organized in the horizontal way, fragmented, it's a different process how we did that, and we put it in the wrong way, vertically. And we wanted to see if the bone healing could actually follow that scaffold process. If we have the empty defect on the left-hand side, there is, as you would expect, basically closure of the defect and the bone marrow is rescued after 3 weeks. If we have the vertical scaffold, so the scaffold placed the wrong way, we have closure of the bone marrow canal and there is no bone bridging. If we have a fragmented scaffold, so not really organized, we have a little bit of bone formation, but not really a large amount. If you look very carefully, you find some endochondral ossification islands. But if we put the scaffold in this way here, we have endochondral ossification in green, yellow is the bone, we have endochondral ossification at the top of the bone marrow. So after 3 weeks, we have an ongoing endochondral ossification process with a lot of nothing and a little bit of highly organized something. If you look into the collagen fiber network over the course of healing, this is again at 3 weeks, you see on the left-hand side the bone mineral tissue, but you see that the whole scaffold is run by fibers from the one end to the other. Also you see that there is a muscle prolapse down here that displaces the scaffold, so we have a connection from those two cortices and these three. So 3 cortices are nicely connected, but 1 not yet. If we look in the process more in detail, we see here that the scaffold-induced endochondral ossification has hypertrophic chondrocytes, it has mineral, and it actually forms bone marrow behind here. Vessels, bone in black, red is the vessels, and the hypertrophic chondrocytes in green. If you look into the same animal in the growth plate looks very similar. So apparently the scaffold allows us to induce a growth plate behavior in the bone defect. How is that looking at 6 weeks? At 6 weeks we have a nice bridging. The endochondral ossification process is still ongoing. The empty defect has closed the bone marrow. And if we compare that to a commercially available product, like in this case the VITOS system, we see that we are much further with that highly aligned scaffold compared to the existing VITOS bone grafting system. What I try to illustrate to you with that is that mechanobiology can actually drive the process. You need a dynamic fixation that allows a certain pumping, not too much. You need a reduction to avoid scarring. And you can influence with mechanical conditions also stem cell behavior. I didn't show that, but we could prove that earlier. Also, if you use BMP, don't make it too stiff fixation because BMP needs mechanics. If you have a very rigid fixation and place BMP in there, the BMP needs much higher dosages. If you want to use lower dosages of BMP to avoid side effects, you need a little bit of flexibility in the system. Again, always a proper reduction of the fracture gap is a pre-requirement. The formation of soft and hard tissues can be really induced by a structured cell matrix interaction, by those railways that I tried to illustrate to you. And the 3D printed scaffolds in the beginning was pretty much the same strategy. So 3D printing opens novel avenues for personalized therapies, but all those findings that I showed to you are substantially altered by age, by gender, and immune status. And many of the examples that I showed to you were in sheep or in rats. How about humans? Just a brief explanation of the role of the immune system. And I tried to sensitize you and get your interest into something which we are usually in the musculoskeletal field in orthopedics and traumatology trying to not so much look into because it's the inflammation cascade. At the beginning of bone formation, if bone starts to heal, there is a very relevant phase, that's the inflammatory phase. We usually try to survive that. We're saying, okay, there is inflammation, and let's get through it. And hopefully it's not disturbing us. Hopefully it's not hindering us, because we want to come to the soft callus phase and then the hard callus phase. We want to see something on the X-ray. But actually, believe me, the most important phase for many cases is the inflammatory phase. And the inflammatory phase is consisting of two phases, two elements. There is a pro-inflammation that's extremely important to get the process kicked off, and there is an anti-inflammation that's important to get good healing. If you have not a pro-inflammatory phase, healing will not happen. If you lack the anti-inflammatory phase, healing will also not happen because inflammation will always be consisting there. So there is a complexity of the different phases intermingling with each other. Angiogenesis is only possible after anti-inflammation has started. To illustrate that a little bit more, we looked into sheep, and we looked into fracture fixation in sheep. One fracture fixation leads in 9 weeks to a proper, nice bone healing. We know that, and we looked into that. We looked into the first couple of hours, and within the first 3 to 5 hours, you have basically an upregulation of CD8 cells at some parts of inflammatory cells, and I'm explaining them in a second. And then in the next 10 hours after the initial fracture, basically within the first 2 days, you have a downregulation of those pro-inflammatory cells, of those CD8 cells. If you have an unstable fracture fixation, if you have a gap situation, if you have a remaining instability, you have a prolonged inflammatory phase. CD8 level stays up. It doesn't go down. Looking into human patients, on the left-hand side, a non-union in a male 56-year-old non-smoker. On the right-hand side, a male 45-year-old non-smoker, normal healing. Healing was qualified by the X-ray and by the ground reaction forces that they could actually produce, so are they returning to full weight bearing? And it was more an accident that we identified that the patients, and that's a total group of 21 patients, that in a patient group, the level of CD8 positive TEMRA cells, generally undifferentiated regulatory T cells, is highly increased in the serum if those patients are non-healers. And that serum level of CD8 is consistently high even without fractures. That's basically what they have and what they carry with them. If we look into fracture hematoma, we see also here an elevation of the CD8 TEMRA levels in those non-healing, impaired healing situations compared to normal healers. So could it be that there are cells that we would consider being bad guys, the ones that hinder healing, that are in the way of healing? And we had in the last session here examples of biologically impaired healing. That is probably something that we're talking about here. If you would take out those CD8 cells, maybe healing is better. Unfortunately, that's something that you cannot do in patients because we need the pro-inflammatory defense system against infections. But you can do that in mice. So if we take out those CD8 cells in mice, and that's illustrated on the left-hand side, at the top, in the wild type, we have the CD8 cells. On the bottom, in the CD8 depleted animals, we lack those cells. They're not there. They are also not coming back. Only a little bit later, after 3 weeks, there is a little bit of CD8 cells again coming. If we look into the bone healing, in terms of bone volume, total volume, or in terms of bone mineral density, the animals that lack CD8 are substantially faster in healing. So if you lack those cells, you're faster in healing. You don't survive infection, but you're faster in healing. So somehow, this seems to be essential and important. So depletion of CD8 cells enhances bone healing. How is that whole coming about? So you basically, when you're born, you get a naive and innate immunity. And you basically have two immune systems, an innate, the one that you get with birth, and that stays constant in your life. And you have a second one, that's adaptive immunity. That's something which you also get in the beginning, but it's very naive in the beginning. And with any repetitive antigen exposure, so any cold, anything that you carry in your lifetime, you basically gain experience, and your experienced immune system gets more and more, and you lack more and more naivety. So the naive system goes basically down the older you get. And if you basically know that there is something like an experienced immune system and immune aging, then some of us have a more challenged immune system and others have a less challenged immune system. And the CD8 cells actually represent exactly that more advanced and more challenged immune system status compared to the ones who have a less experienced immune system status. Can the experience of immune system alter healing? The more experienced your immune system is, the less good is your healing. On the left-hand side, we have a very unexperienced, naive immune system, but basically like in a baby. It's a mouse femur here, and that has been fractured, stabilized with an external fixation, and you see in the micro-CT, the bone has bridged and the bone healing is more or less complete. The bone marrow is opened. On the right-hand side, we have an experienced immune system with 4 weeks of exposure. So the mice were kept in a natural environment where they would see antigens from other animals, and suddenly healing is retarded. So why is something that is otherwise good for us really hampering our healing capacity? So this is here true. Only the experienced immune system retards the healing, and healing is less good in an experienced immune system compared to the naive. That explains why kids heal so fast their bones, because they have a very naive immune system that supports and helps them. So on our way from mice to humans, can we go one step further? Can we basically make humanized mice? And so we did that. We basically took from one of our naive patients, we characterized our patients and characterized if they're naive or very experienced. And we took the immune system of an experienced and of a naive and put that in a mouse and looked into, is that actually capable of producing the same in a mouse model system? And you see on the left-hand side, the naive system comes to more bone formation, more reddish, darker colors represent more mature bone, while the experienced immune system is retarded in bone healing. If you quantify that, the bone volume, total volume, or the bone mineral density is higher, substantially higher in the naive compared to the experienced, even if we use human immune systems. Going back to our patients, the group of the 21 patients that I mentioned to you earlier with the two examples of a good healer and delayed healer at the top. I illustrated to you those graphs. So basically in the serum and in the fracture hematoma, we find those bad guys, CD8 cells, being elevated. Is that the only one? Are we only having bad guys, or are there not good guys? Yes, there are good guys. The good guys are the CD4 regulatory T cells. And what we could realize in our patients is if we have a good ratio of good guys and bad guys, so not enough so enough good guys and not too many bad guys. So that ratio actually plays the central role. And what you can see at the bottom is in the peripheral blood and on the right-hand side in the bone hematoma of the patients, we find a highly upregulated CD8, CD4 ratio. And even in the ratios, it means if you're a good healer, you need enough CD4 to counteract your CD8 levels. So probably it's not that you have too many bad ones, but probably you lack too many good ones that really delays your healing. So adaptive immunity, that's what I tried to introduce to you, modulates healing. So please be aware of the patient immune status or the immune age. And usually we don't look so much into that because we're planning our surgery. We're not really, in all cases, so aware what is the rheumatoid arthritis status, what is the anti-inflammatory drugs that the patients have really taken the last time before they actually come on our table. We know that the immune system changes with years and with exposure to pathogens. We have identified CD8 positive T cells as being the negative guys, and we have seen that there needs to be a ratio of good and bad guys. What we're doing at the moment, and I cannot present that to you right now, we're developing with a larger company a test kit that will enable you to basically from a droplet of blood drawn from the patient coming into the emergency room that you know that patient is a patient at risk or a patient with very good healing potential. But it's not yet available. It's in the clinical phase approval trial. Can we learn from bone healing also for other tissues? And that's my last part I'd like to illustrate to you. Can we learn from bone for muscle regeneration? If there are good guys and bad guys, can we modulate them also in muscle? Where do we need muscle regeneration? Whenever you do a joint replacement surgery, you destroy muscles when you go to the joint. Whenever you do fracture treatment, muscle has already been damaged in the injury and the accident, or you do an additional injury in the surgical process. If the muscle is damaged, the muscle gets fatty degenerated and gets atrophic and produces scar tissue. There are other incidences where you have muscle injuries resulting in scar tissue and fatty degeneration. What we would like to have is an intact muscle, and what we would like to do is really boost the anti-inflammatory phase to enable muscle regeneration and avoid fatty degeneration. Here's a little bit science fiction. We're trying to think of, could we actually have a scaffold, a biomaterial, that we place on a damaged muscle? We put in that scaffold stem cells, mesenchymal stem cells or stroma cells. They would actually exert the paracrine factors and by that modulate the immune system in the muscle and enhance healing. And that looks so nice and looks so easy, but how is it actually possible to do? So we could show that in a rat system, that in rats we can, after a crushed muscle trauma, apply stem cells in such a biomaterial, and we can, with a stem cell application, enhance substantially the muscle regeneration capacity. What is shown here on the right-hand side is at day 7, day 28, and 56, so over the time course of healing, the amount of muscle force, in this case fast twitch, compared to the contralateral intact uninjured muscle. So we're at day 7 at 50% damage, and we're basically recovering at day 28 and 56 to roughly 80% if we have stem cells in the place. What do? They make the immune modulation along the lines that I just illustrated to you in the bone healing. We also have a reduction in scarring, so we have less scar tissue if we have those stem cells in place. Now, that is all nice, but where do you get stem cells? Is there any way of having a solid perspective for the clinical usage? And we were lucky to find a company, an Israel-based company, Pluristem, that provides us with stem cells as off-the-shelf products. And that is, to us, a very cool strategy. So that company provides from placenta cells expanded, basically prepared them, and provides us, after 3D expansion with downstream detachment and washing, 2 products. And we are using the PLX PRAT system. So it's a stem cell that is off the shelf, available to induce regenerative processes. Could that actually help us to induce regeneration in a patient that comes walking in and where we cannot say, wait a moment, we take some stem cells from you and we will prepare them, and in 3 weeks, 8 weeks, 10 weeks, we will give them back to you. No, we would have them right away from the very first moment. We looked into that in our rat model system that you have seen before, so crushed muscle trauma, and we could see that the stem cells, the PLX cells, actually induced higher fast twitch and higher tetany than the controls. And the interesting thing is we applied them later, after injury has covered, and in the anti-inflammatory phase. But in most cases, you would like to apply them immediately, directly. So we also tried the immediate injection when we did the surgery. Could the cells still do beneficial effect? And they could. We could actually induce muscle regeneration if we put the cells in the right place from the very beginning. Now, what about human applications? Could we actually go to a human trial? So if we would like to apply those cells to basically reduce the scarring that you see here in that case and come to an instant competent muscle. And we have seen that those cells are pro-angiogenic. We have seen that they are immunomodulatory by anti-inflammatory capacities. And we have seen that they can induce muscle regeneration. And we started, after approval by the EMA authority, the European agency that needs to approve studies, we induced a phase 1, phase 2A study, and we could show that there is a positive effect of those cells after total hip replacement surgery. We did that trial in 20 patients. We had 3 groups, and that was the only size that we were allowed from EMA to do that study. We had a placebo group, we had an intermediate dosage of 150 million cells, and we had a high dosage with 300 million cells. If we applied those stem cells in the moment of finishing the surgery, you suture the muscle, you go out of the surgical field, and then inject the stem cells. We have in the muscle regeneration capacity, so here's the muscle force, how is muscle force recovered, and you basically see that the placebo group is only slightly recovering the muscle force compared to the contralateral side. We see, however, that there is our high dosage, 300 million, peaking, the muscle force then reducing slightly and covering in the mediate. And the medium size, 150 millions, actually go all the way up, and the muscle regenerating capacity compared to the uninjured side is substantially increased by the stem cell dosage. Okay, muscle force is one thing. What about muscle volume? We wanted to avoid scar tissue. If we look into the muscle volume in the MRI, we see also here the intermediate dosage of 150 million produced the largest muscle volume or the biggest recovery of muscle volume seen in all of the patients. Where is that actually coming from? And I introduced you so heavily into the immune system. And what is happening here is you have those good guys, the CD4 cells, and if you have the PLX cells present, if the stem cells are there, we basically have less reduced number of CD4 cells compared to the high dosage or the placebo no stem cells. So basically, you have a positive effect in the beginning of the onset of healing. After 2 hours, very early. After 7 days, it basically has gone away, and the stem cells, high dosage and middle dosage, pretty much show the same effect on the CD4 cells. But why are the 300 million cells not better? Because more is usually better. Why is not 300 more better than 150 million cells? So why that difference? And what we could see at 2 hours after surgery, you have a surgical stress level, illustrated by IL-10. So any surgery that you do induces stress in your patients. And that stress level is substantially reduced in the presence of the stem cells. But only in the 150 million groups that doesn't peak up, but in the 300 million groups it peaks up again and basically comes to a second hit. We think that the stem cells are dying because there are too many, and only with 150 million dosage we could survive that in a really moderately post-operative stress. So if we actually modulate the post-operative stress, could we actually use that to go beyond? And what we're doing, and I cannot show you the data because we're just opening the trial in January, we now do the EMA phase 3 approval trial. It's a multi-center trial, and we moved it not from primary hips, but we moved it to femoral neck fractures. Because femoral neck fracture patients come with a muscle trauma. We put an intraoperative muscle trauma on top of a fracture. We usually have sarcopenia and we have elderly patients. We have impaired immobilization and surgical stress, and we have a high mortality. We try to help those patients, and we would like to reduce mortality. This is a multi-central trial, 14 locations on a global scale, North America, Europe, 240 patients in total hip arthroplasty, and we will inject the stem cells at the site of the muscle injury after the hip implant has been in place. With that, I'd like to finish my talk and like to sensitize you, starting with the beginning. If you think about rescuing people and regenerating bone and muscles, there is no way to avoid the loads that are acting in the human body. And that is one of our young patients wearing a total knee replacement, and we're measuring the forces in the knee replacement. And you see here, the resultant force is easily up to 6 times body weight, 6 times body weight in that patient, in that very simple activity standing on one leg. And if I ask the same task to a slightly older lady, please be aware, she's standing on a swing platform. And look at the forces. She has 3 times body weight. And sometimes it's not only important how big the forces are, but sometimes it's important what your attitude is towards basically recovering your musculoskeletal system. And that lady certainly does better than the slightly younger patient. Take home messages. I try to illustrate inflammation cascades. Please keep the hematoma in place. It's a miracle soup from which everything starts. Don't take it out. If you see it, it's already in the anti-inflammatory phase. You have no chance to help the patient by taking it out. You actually delay healing easily by 1 to 2 weeks if you take the hematoma out. There is no chance to really do partial weight bearing because your patients will load the limbs. Whenever you say and prescribe partial weight bearing, it's already a rescue mode. It's always there. You can just avoid stumbling events. So give them crutches to avoid stumbling, to avoiding extreme forces. But forget about telling them 15 kilos, 17 kilos, 21 kilos. There's no way that they can actually cope with that. Just tell them there's a crack under your foot, be careful, and don't run, don't do anything, don't stumble. Dynamic fixation is cool. Don't make it too stiff, don't make it too flexible, and what I should have put in here, avoid any gaps. Any reduction is key. If you don't reduce enough, you will have the scarring and the cells go the wrong way. They will close the bone marrow cavity. Realize the immune status of your patient. It sounds very fancy, it's actually not. You should know if the patient is a smoker. You should know if the patient is type 2 diabetes. You should know if the patient is taking rheumatoid arthritis drugs, or is the patient otherwise immune compromised after transplant or cancer therapy. And finally, respect in any surgery the muscles. They are key to any healing in bone, and they deserve it themselves. So in surgical approach, in intraoperative handling, and induce muscle regeneration if possible. Those are the funding sources. I hope I could illustrate a little bit new perspectives here and there, and I'm very honored that I could give this Dolaki lecture today. Thank you very much.
I thank Professor Duda for delivering a wonderful lecture. Please accept the token of appreciation.